I know I clicked, and then like purely for selfish reasons. Yeah. There's no need to get out of it. You don't have to do that yourself.
All right, hey everybody, we're going to get started. So I just want to take a minute. If you could all please give a round of applause for all the volunteers who stepped up today and helped table and also, just a special shout out to Jamie Peck and Andrea Bocos. Without them, this event would not have been possible. They put a ton of work into making this. Jamie, take it away.
Thanks, Ben. Shout out to Ben as well. Woo! I'm sorry. Okay, so now we have a very exciting speaker, Tim Faust. It is the Chavo House healthcare correspondent and is pursuing an MPA in health policy and finance at NYU's Wagner Graduate School of Public Service. He has been traveling all over the country, dropping knowledge all over the place about Medicare for all. Please give a warm North Brooklyn DSA welcome to Tim Faust.
Howdy, y'all. Actually, just dropped out last week of my MBA program. The one thing better than going to grad school is not paying money to not go to grad school. It's wonderful. Hi, my name is Tim. I've been with DSA driving around the U.S. talking to locals, church groups, law schools, whoever really will have me about single payer. And more importantly, the idea of health justice, the broader articulation and moral compulsion of a better world that lays beyond. So I'm going to give a little 15-minute kind of run through the things that I talk about. This is very exciting for me. One, because it's fun to talk here in New York where I live. Thank you so much, North Brooklyn DSA and the Socialist-Feminist working group for putting this all together. But also, because this is the first time I'm giving my speech to my dog. So it's shorter than usual because he's a dog, he's got a short attention span. I think I'm talking for 15 minutes, which is what? 95 minutes in dog minutes? So bear with me as we kind of put this through. All right, I want to talk about healthcare in America. I want to talk about health finance, the things that we are forced to endure, the things that we want instead, and then kind of the moral compulsion that lays beyond, the broader vision of a better world of health justice. Before we get into that, I want to start off by confirming something you already know, something you probably feel pretty deeply in your bones, which is that when it comes to healthcare in America, you're being fucked over. And the method by which you're being fucked over, or the severity, or the complexity, or the artfulness of the cover-up, varies from person to person, but fundamentally, we have created a world in which you are made sick and then punished for being sick, so that somebody else can make a huge profit. Because you see, there are two fundamental truths to healthcare in America. One, if you're a payer, like an insurance company, it's just not profitable to insure people who are sick. 50% of all medical costs in a year come from 5% of the population. So if you're an insurer and you pick up one of those sick people, for example, somebody with hemophilia whose care can cost up to $1 million a year, you're just not going to be able to perform your stated goal of delivering maximum profit to your investors. That's just not going to fly. So you've got to find ways to kick out sick customers or coerce them into leaving. Maybe you drop coverage for drugs that sick people need, or cut off access to providers or hospitals or physicians who treat the sickest patients. Because the task of an insurance company at the end of the day is to make sick people, as much as it can, somebody else's problem. Two, if you're a provider, like a hospital, it is extremely profitable to charge sick people as much as possible, as late as possible, as long as somebody's footing the bill. Now, healthcare unit costs have been rising since we first began recording them back in the 1880s, way, way faster than inflation. Part of these cost increases are for good reasons, right? More people are living longer with chronic conditions. Things like asthma, diabetes, cancer, trauma aren't the immediate death sentences they were even 2 or 3 or 4 generations ago. So we spend more money to take care of more people long, which is a fantastic way to spend money. But most of these cost increases are because hospital CEOs, equipment manufacturers, pharma companies, close personal friend Martin Shkreli, keep finding more and more ways to charge more money for the same services. Maybe they buy up local clinics and all of a sudden charge hospital prices, or maybe they rack up fees for unnecessary services and no small insurer can stop them. And so upon these jagged rocks, we built the Church of American Healthcare, in which the body is valued solely as a source of profit. Now, this fragmented, commodified healthcare model views healthcare as a transaction instead of a relationship between a person, their community, their body, and their doctors. That's fucked up. We've just mistaken the profit motives of corporations for healthcare. And the problem with profit motives is that, I mean, this is a DSA meeting, I didn't tell you what the profit motives are, but let's add this to the litany of sins. Profit is irreconcilable with long-term population health. Because your private insurer only cares about your health so long as they're insured, right? Because you're going to change insurers in a couple of years and, God permitting, one day go on Medicare. Insurers feel no pressure to invest in the kind of care that keeps you and your neighbors healthy in the future. Instead, we all do, right? Because we all suffer when our friends and family get sick and our public money is allocated to care for folks in times of crisis and catastrophe. This isn't a complex idea, right? I think you all understand this already. You all understand, for example, that if it's the winter and your window gets broken, the cold gets in, right? And if the cold gets in, you're going to get sick. And if you get sick or if your kid gets sick, you got to go to the doctor. And if the local clinic was shut down or it's booked solid, you got to go to the hospital. And if the hospital is far away or you don't have a car, you got to take the bus or the train. And if you got to take the bus, you got to spend all day dealing with the bus system. And if you got to spend all day dealing with the bus, you can't go to work. And if you can't go to work, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a big pile of cash every time you go to the hospital. The answer begins with fixing the goddamn window and then making sure people have the time and resources to take care of themselves. But instead, well, yeah, that would kick ass. But instead, that's not what we have. The multi-payer, profit-driven model chooses to invest in pleasing, extractable resources, right? Which is the customer base of healthy and wealthy people, while abdicating any responsibility for taking care of sick people or of providing the material relief which keeps people from becoming sick. We've built a multi-tiered system in which the temporarily able-bodied are given trinkets and praise and attaboys and attagirls so long as they remain able-bodied and able to pay. People who are sick or people who are poor in the communities in which they live, communities that have been actively deprived of capital and drained of labor, urban black communities of the rural poor, instead they are systematically, if not violently, denied access to care altogether. And so here's the table stakes. Among so-called developed countries, it is America that is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black, the most dangerous place to be pregnant, with the highest maternal mortality rate of any country in the first world, of which 60% are entirely clinically preventable. America is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. Last year, life expectancy at birth fell for the first time in over 30 years by 1/10 of a year. Across the 4 million people born last year, that's a theft of 400,000 years. A funny thing happens when you look at the data more closely, right? And you know exactly what I'm going to say because it is woven into the American fabric. When you look at the data more closely, you realize all this danger only exists if you're poor. Because rich people are exempted from all of these problems, men born in the wealthiest fifth of America get to live 15 years longer than men born in the poorest fifth. Among women, that gap is 10 years. Your zip code is a better predictor of your life expectancy than your DNA. People in poor East Cleveland have a 21-year shorter life expectancy than people in wealthy Lyndhurst, 8 miles to the east. People in Hunters Point, San Francisco, where the ground has been made toxic while the city looks away, have a life expectancy 14 years shorter than people in the Mission. And within the last decade, the infant mortality rate among communities of color in Memphis, where there are 2 nuclear waste disposal facilities flanking the poorest neighborhoods, was 20 per 1,000 live births. That is 5 times the national rate. This is war. This is the terrible secret of American healthcare. They are killing us and robbing our corpses. there are no private actors in the American model who will ever consider bearing responsibility for fixing these problems on their own. The insurance industry is incapable of addressing the foundational problems of healthcare, right? Of fixing the broken windows, of cleansing the soil, of reopening the 18 rural hospitals that closed in Tennessee in the past 5 years, of fixing the ruptured PVC septic tanks in rural South Carolina that have brought hookworm back to the state, a thing we thought we cured 60 years ago, in the exact same way that a billionaire is incapable of lessening income inequality, or a cop is incapable of shrinking the prison industrial complex. They cannot fix this injustice because they have been constructed by and within that injustice. They cannot solve these problems of healthcare because they existentially cannot conceive of them as problems in the first place. But we can, and we do. And so it makes perfect sense that the same actor who suffers when people don't get care, which is all of us united, represented by our federal government, should be the actor that pays for that care in the first place. A federal single payer we want that offers comprehensive coverage, including dental, medical, vision, and long-term care that is free for all people in America. Because once the federal actor is forced to bear the costs of providing care and the risks and costs of not providing care, it can finally be used as a tool for realizing health justice. If your people are getting sick and dying because they don't have a place to live, or if the places to live are unsafe, they're full of pollution, they're full of mold or flammable, I'm thinking of the Grenfell Towers in the UK or ghost ship back home in Oakland, then housing is healthcare. And you must build safe, free housing to bring healthcare costs down. If people are getting sick and dying because they don't have access to healthy food to eat because it's not profitable to sell a poor person vegetables, so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you must provide people with affordable or free food options and the time, space, and materials with which to prepare them to bring healthcare costs down. If your population is getting sick and dying because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And not our current myopic, end-of-life, palliative care, only focused model of rehabilitation, but the full social structures required to help people handle substance use, or perhaps not fall prey to it in the first place. That's how you bring healthcare costs down. Because single payer, because Medicare for all is not the goal. Single payer is the tool. Health justice is the goal. And when we fight for health justice, we all fight side by side. Because economic justice is health justice. Environmental justice is health justice. Reproductive justice is health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for the lives of immigrants, and the well-being of all people, regardless of age, creed, gender, or race, that's health justice. We have inherited a world in which your permission to receive health care, capital's allowance you can be safe in your own goddamn body, is dependent upon how much somebody can extract a profit from you. And thus, we have permitted in our country utter desolation. Without our consent, we have been forced to participate in the condemnation, criminalization, and abandonment of people in need. People with disabilities got to spend tens of hours a week pleading with insurance companies to maybe get a chance to go on a waiting list to receive the bare minimum care required to keep them alive, if they're lucky. The unlucky ones got to plead with Medicaid or Social Security to maybe consider compensating their partners, friends, or parents a whopping $1,000 a month for taking care of them full time. Elsewhere in America, we have the opioid epidemic, which is an epidemic whose vector is capitalism itself, which was originally manufactured as a patent extension ploy that now kills 180 people a day. Those it doesn't kill are written off as criminals. And we saw it before in the crack epidemic and heroin before that. Who gives a shit about criminals' rights? They're the untouchables. We throw them to jail and let them rot as their children call their names. People who suffer from chronic pain are marginalized and stigmatized and punished for the sin of being born in a body that hurts. In life, it is the poor and uninsured who are used to test the drugs that are then turned around and sold to insured people. But that servitude continues in death, as it is the bodies and organs of the uninsured and poor who are ripped and sold to the wealthy as transplants. Because there is no end to the body horror of capitalism. There is no line too far to the commodification of the body. America has cheered the privatized slashing and burning of social structures, and then has the audacity to punish people for struggling. When people are in need, we waste time, effort, and money means testing, separating the worthy from the unworthy among those who need help, and then punishing them instead of guaranteeing the basic decency of health equity. This is cyclical. This has happened forever, and it will continue to happen so long as we permit, even in whispers, the idea that the body is a commodity. And for systematically marginalized people, right? Sick people, homeless people, people struggling with addiction, people with disabilities, poor people, pregnant people, trans people, women, and people of color. Well, this is America, when there's no way for the medical industrial complex to find profit in their bodies, then there's always the private prison system that is ready to receive them for profit. And so single payer is not the revolution. It is our first counterattack in a war that is already waged against us, by which subsequent counterattacks are made possible. Single payer is not only the only reasonable method of controlling healthcare costs while guaranteeing universal coverage. It is the tool by which we force ourselves and force the state to reckon with the racist, sexist, and classist provision of healthcare in this country, and to begin to strive toward relief and articulation of health justice. My friends, single payer is moral. Single payer is necessary. And single payer is achievable. Solidarity now, solidarity forever. Solidarity, y'all.
Thanks, Tim. That was a great speech. So now, hell yeah. So now I would like to introduce our panel. We have some excellent people speaking on this panel. You've already met him, but Tim Faust is a healthcare expert, Jacobin writer, and co-host of the Heavy Medical podcast. We have Emma Caterine, who is a writer and activist working within economic justice, feminist, LGBTQ, and racial justice movements. Julia Salazar, who's coming up to the stage right now, DSA member running for New York State Senate in New York's District 18. And we are going to have the panel be moderated by Michael Brooks, my friend and colleague, host of the Michael Brooks Show and co-host of the Majority Report with Sam Cedar. All right. You guys can pass that mic around if you want.
I'm passing.
You can take this one.
Wait. And hopefully this won't knock over. Just first of all, obviously, thanks for being here on Saturday afternoon. This is actually a really good turnout, I think, for anything political. So thanks, everybody, and thank you for having me be a part of this. I'm honored. I wanted to start, this will be like basically how we'll do the introduction, is each of you to tell sort of your healthcare story, like what made this a point of activism for each of you, and then you can also use that as a way to, tell us who you are. And I'm gonna do this operation where I get the mic over to you.
Hi everyone, my name is Caterine. First off, I just want to thank my family for being in the audience. This is the first time we've ever seen I've been a activist and a socialist for about the past 10 years or so. But in terms of focusing on this particular issue, I think it really hit me when, how many of y'all have been to Reese Beach here in Queens, in Rockaway? A couple of y'all? It's a really good beach, you should check it out. It's the only good beach in New York. But I enjoyed it a little too much, and I wound up passing out from heat exhaustion. And they put me in an ambulance, and they took me to the hospital, and they were like, "You idiot! You were having like 8 hours and barely drank any water." And so I was like, "Well, that was dumb. Oops." And I went home, and I was just like, "I feel so foolish," and I thought that was it. And then a little while later, I get this bill for, it was, I think it was something like $1,800. And it was just for the ambulance. And I was like, "Look, that can't be right. I have insurance. My insurance should cover this." And so I called my mom, because I believe I was still on my parents' insurance at that point. And I said to my mom, I was like, "This should be covered, right?" And she's like, "Yeah, I think that should be covered." And we were trying to look into it, and we were fighting with the insurance companies and this and that, and eventually the insurance company sent me this very scary looking bill and said, "You must pay this within 30 days." And so I was like, all right. So we pay it, and then despite paying that, 30 days later, I got another letter from them saying, "We've sold your debt to a debt buyer." And at that point, I kicked in, because I just graduated from law school, and my area of focus is consumer debt. And so I was like, "Oh, you picked the wrong person to do this to." So, I threatened to sue them in 8 different ways. And for some reason, they were like, "Oh, wow, it was totally our mistake, sorry." But, working in the courts with this work that I do, I've seen lots of people who have faced these same exact problems with medical debt in particular. And I joined DSA after going to a Socialist-Feminist meeting where single payer was voted as the campaign that we would be taking on. Yeah, that's my healthcare story.
Yeah, you can clap for him.
Usually no clapping is allowed.
Hi everyone, again, my name is Julia Salazar. If you don't know me already, I'm running for state senate in this district. We are currently in the district that I'm running in, if that wasn't clear, the 18th. And as far as my personal healthcare story, I've had a lot of experiences with being denied care far more often than receiving medical care, and also have medical debt as a result of going through a time of being uninsured. Even now that I have insurance through my employer, which I'm really grateful to have, it's still a narrow network, so I face a lot of the issues that many of you have probably dealt with in just trying to get basic medical care in the US. My introduction to actually organizing around healthcare and care in general was actually through my experience of being a domestic worker. Ultimately led me to join something called the Caring Majority Campaign, which is a campaign of seniors, people with disabilities, domestic workers, home care workers across the state, fighting for universal long-term care, which is actually, long-term care is frequently not covered by Medicare. So even when we talk about the New York Health Act, which of course is very important in passing single payer in New York State, which we will absolutely do, I think is crucial, but there's still a gap in care that a lot of people, particularly seniors or people with chronic conditions, people living with disabilities, have to face. But in my experience of advocating with the Caring Majority, actually about a year ago, I went to Albany on a lobby day with a lot of other domestic workers, and during one of my legislative meetings, it was with my assembly member, Eric Dillon, the son of the state senator, in our healthy democracy. My state senator is the father of my assemblyman. But I was in a legislative meeting with Eric Dillon and two domestic workers, one of whom lives in the district, the other from Queens, and we were just presenting the platform of this campaign, demanding universal health care, including long-term care for all. And he listened to our spiel, and eventually he said, "Yeah, I don't think that I can support this because I have a conflict of interest." And then he explained that his wife worked in the healthcare industry. So that was really eye-opening and surprising for me to hear. And now I'm running for state senate and challenging, Marty Dillon. So certainly that has been part of. It's motivated me to continue to actively fight for this issue, but additionally to consider how we need to get legislators out who are corrupted by private interests, whether it's insurance interests or profiting off of sick people and people not being able to access care directly.
Great.
Howdy. When I was 18, I was an EMT in North Houston, and most of my time as an EMT involved going out to the north part of the city and seeing folks who didn't want to see me. No one's happy to see an EMT worker, right? You're not doctors, you're not nurses, you don't do anything nice. You help folks hurt a little bit less than drag them to the hospital. No one's happy to see you, but a lot of folks weren't happy to see me for reasons that I hadn't considered. They didn't want to get in the ambulance. They were afraid of going into debt, going broke. People who were pregnant and in severe pain, people with big rashes, big tumors, big lumps, people that had been hit by cars, people that were bleeding out, didn't want to get in the ambulance because they were afraid it would bankrupt them and their family. That's fucked up, I thought. A couple years later, 2013, I worked in Florida, Georgia, and Texas on the ACA. This is back before we knew the ACA was a failure, but before the expansion of Medicaid. And I was a young idealist. I thought the ACA might help people in the individual insurance market. And so my job in Florida, in Orlando, which is where my apartment was, has a quarter of the city that has been systematically deprived of capital and labor, right? OBT, Orange Blossom Trail. A neighborhood where the houses aren't safe, it's not safe to exist, life expectancy is shorter than the rest of the city. And so I spent a lot of time going to the OBT, talking to folks, seeing if they're eligible for the ACA. And of course, none of them were, because Florida's a Medicaid gap state. Georgia also a Medicaid gap state. Texas a Medicaid gap state. And that broke my brain. So I saw people who were suffering, and I saw a bill that promised to alleviate their suffering, and I saw elected officials who refused to do the fucking easy, decent, and free thing to help them out. And I thought that in democratic politics, then you want to get elected. And I was proven wrong several times. So the process of seeing people who were suffering, people who were living in trailer parks, people who didn't have teeth, people who had life expectancy shorter than, how old I am now, were again and again and again being denied care because they were either too poor or the wrong kind of poor. And I guess the umbrage and the ire and I think the raw, yearning for something better I felt then, felt ever since.
Absolutely. So when we think outside of this room, obviously, I think the primary, and correct me if I'm wrong, it seems like in most areas that we need to deal with major injustices and challenges and wrongs of capitalism and these kind of systemic transformations that we're working on, you guys are working on, the raw reality of just money and power and just literal influence is really obvious. But I think we're also going to have to debunk some myths that still live in the sort of public consciousness about healthcare, about the, here you know, we have the Mayo Clinic, and we don't go to Canada, right? Like that sort of stuff is obviously not in this room, but it's still somewhat in the atmosphere. And so I guess I'm curious, what do you think the sort of main myths are, or maybe not? Maybe they're exaggerated in terms of how the media reports on this story. Obviously, polls show most people are pro single payer in some fashion. But what kind of myths do you think we're going to need to overcome to really sort of mobilize broadly and actually win on this issue? And I'll just go reverse, starting with you.
All right, well, I've spoken all over the U.S. and I've spoken to some pretty rural and pretty conservative areas. And the good news is that everybody's in favor of single-payer language. This is not a radical proposition among people that affects. But there are certain myths that exist. Which one should I bite off first? The easiest one to get out of the way is the idea that this thing costs too much, that single payer represents an incredible incremental cost that we can't afford. That's wrong for a bunch of reasons. First and foremost among them is that we're literally already paying for it, right? A single payer program, right now we spend what, $3.2 trillion per year in healthcare costs? 2/3 of that is direct federal spending. Half of that is direct Medicare and Medicaid VA spending. Other half is just federal subsidy to private companies, tax breaks, etc. The remaining third is out-of-pocket costs. Premiums, deductibles, co-pays, balance billing if their hospital bills you. And so the goal isn't necessarily to invent new kinds of spending or even reduce that spending. It's to reallocate it, take care of everybody long-term, full stop. Instead of putting the yoke of rising healthcare costs on the individual who is unable to afford them, and then to coerce the individual into thinking you're using healthcare wrong if you go to the hospital at the wrong time, whatever, to use the power of the single federal payer to, one, price set so costs stay flat or drop, and then two, through novel ideas of progressive taxation, take what we're currently spending and use it to fund a single healthcare payer. Under our current model of multi-payer spending, annual healthcare costs are expected to hit 4.4 trillion by 2027. So we can't not. It's not that we can't afford to do single payer. We can't afford not to. Costs keep rising so high. We're just going to push those costs on individuals. So the cost question is moot. Of course, the wealthiest nation in the history of nations can afford to pay for single payer. It's the very, very least it can start to do. A secondary fear that I hear a lot, and I'll cap it at 2, is the idea that a single payer takes accountability or takes your ability to control your healthcare out of your hands, right? Putting it into this nebulous government entity, which of course is false, because right now all these decisions are put in the hands of private companies. And no matter how mad you are, you can't vote out Aetna. You can't storm protest against Blue Cross Blue Shield. They don't give a shit about you. Of course, there are a lot of risks in any kind of government agency, right? The government has been very, very good at being complicit, if not building itself, the kinds of systematic deprivation and oppression that especially affect marginalized people. But under a single payer, you have the means by which you can hold that single payer, to hold those decision bodies accountable, right? You can yell at your elected, you can vote them out of office. You have the ability to wrest control from that power. Right now, you have no control. It's all determined by people in boardrooms that you can't even go look at. So those 2 myths, I think, luckily have nice populist answers that are correct.
Nice populist answers that are correct. That could be a podcast. Everybody's podcast does. Snag that name.
Nice populist answers that are correct. I'll try to give a nice populist answer that's correct. One myth that I think is pretty common is this idea that if we had a single payer system, there would be very long lines for care, or that you would wait a long time to see a specialist, and that this is the case in other countries, in Canada or in European countries, but that simply isn't true. The data of the polls of people who live with universal health care, it demonstrates that people are generally very happy with their health care. As you can imagine, it's great to not have to pay to see the doctor when you're sick. But additionally, I think that this myth comes from people who don't really have their ear to the ground as far as what everyday Americans experience in trying to get health care. That, I've personally experienced trying to see trying to make an appointment with a specialist and being told that it would actually be months before I could see a specialist. This is really common, and that's something that exists even in our for-profit healthcare system. So.
Okay, so I'm going to talk a little bit. It seems like we've addressed some myths of single payer, so I'm going to address some myths about the Affordable Care Act, since unfortunately I think one of our biggest impediments is actually the Democratic Party itself, and the fact that it's more committed to sort of entrenching the Affordable Care Act than supporting single payer. So the Affordable Care Act was essentially passed under the premise that the main problem with healthcare was that there wasn't universal coverage. But the fact is that 26% of the US population has missed a payment on medical debt at some point in their life. And 77% of those people had insurance when they missed that payment. So the biggest problem, at least in terms of personal financial problems, is under coverage rather than no coverage. The other is that the Affordable Care Act and other programs like Medicare and Medicaid are sufficiently covering people who cannot afford to pay. That's also not true. One of the parts of the Affordable Care Act that I was really excited about, and a lot of people are excited about, was a provision called charity care, which provides subsidies to hospitals to cover or mitigate the cost of care to people who fall in between that gap between not poor enough for Medicare or Medicaid, but not wealthy enough to be able to afford insurance. And unfortunately, when you deal with for-profit entities, what are they going to do? They're going to make decisions to make profits for themselves. And so, of course, what the hospitals and insurance companies did when the government said, oh, we'll give you these big tax cuts if you provide people with free health care. Well, the hospitals and the insurance companies said, oh, yeah, we'll do that. Just give us the money first. So I know in the state of California alone, they had a $1.5 billion shortfall in terms of money that was supposed to be spent on charity care and wasn't in the year of 2013 alone. Fortunately, there hasn't been enough studies on that. We'd all like to see more. That was done by the National Nurses Union, fabulous partners in this struggle with us. And the last myth is that that the American people have finally realized that the Affordable Care Act is good for them and they'll be satisfied with it. That's not true. The American people, of course, are absolutely terrified of the alternative that Republicans are putting forth to them. But even in this current state where the Affordable Care Act has reached its height in popularity, it's still only 57%. Because people, they see their premiums go up. They see the stories of their neighbors and their friends who are still falling through the cracks. And of course, the Trump administration is very cleverly sabotaging the Affordable Care Act, taking advantage of all of its weaknesses and leveraging those to make people hate it even more. And so really, the Affordable Care Act, we can't just keep defending it. We have to go beyond it and push for single payer.
Let's actually stay on that for a minute, because I think dealing with Obamacare, ACA is really important in all of this. And I guess two-part question, all of this. I'll start with you this time. Do you think that one perception is that as flawed as it is, and we see all of the internal contradictions, and you just outlined them perfectly, and I don't need to re-review them, I think, for this room. So we know that it's best case scenario, totally insufficient for the goal of a just, basically ethical healthcare system. Did it raise people's standards in the sense that before Obamacare, it was just accepted that there's going to be 40, 50 million people that just don't have coverage, it's a consumer commodity and they can't get it. And incidentally, even when they can get it, they can be medically discriminated against and all the rest, like things that are ludicrous, but were just accepted in American politics. So, one argument I've heard is, as flawed as it is, it raised people's expectations very modestly, obviously, but it sort of recentered the conversation. Conversely, there's what you outlined, which is that, does the sort of stuff that you'd expect to hear from like a Neera Tanden about how, secretly, mystically great this program is, and, people love to spend hours on weeks on websites, like figuring out how to buy bad plans that are founded by Kushner's brother, which, people know that Oscar, that's Jared Kushner's brother. Yeah, I'm sorry if you have Oscars. Give you all some bad news, on top of all the other bad news. If you ever needed a real reason to have universal health care, think of your money going to Jared Kushner, even indirectly. But that actually in the push to defend Obamacare, that is, and the sort of partisan identification of that is actually filtering on the other end. That, so again, those dichotomies, it's bad, but it's raised the expectation game, or it's totally insufficient and it's become another thing that people can sort of rally around as like, a great democratic achievement that's under siege by Republicans, if that makes sense. In terms of like how it plays out with, I guess, more democratic-leaning voters as you talk to them about single payer and really eliminating private insurance. So I'll start with Julie.
Sure. Just in my own experience speaking to constituents and canvassing for the New York Health Act, I actually don't encounter that kind of pushback. People don't typically bring up the Affordable Care Act. So even though in virtually every conversation I have, even if someone might say, I get insurance through my union, or I have Medicare, they are acutely aware, whether it's their family member doesn't have coverage or is at risk for losing coverage, or someone else they know, they're acutely aware that there are huge gaps in coverage, even after passing the Affordable Care Act. And we can consider that the Affordable Care Act gave many more people, even myself included at the time, access to health insurance for the first time. That we also have to recognize that it's deeply inadequate, and we can say that as progressives, that we have a bigger political imagination than simply, people fought really hard to pass this legislation, and that we should be grateful for it or accept it.
Imagination that,
yeah.
Aetna should be able to hey, you have a pre-existing condition, you can get minimal coverage, we can actually do better than that.
Yeah. Yeah, absolutely.
So first off, I don't know what Neera Tanden thinks because she blocked me on Twitter a long time ago. I made the mistake of asking her if the donations from the United Arab Emirates or the Walton Foundation influenced her decisions at all. I guess so. In terms of, I think there's a little bit of a misconception, and you get this generally with politics, and especially politics in the United States. We have a lot of historical amnesia. There have been people advocating for single payer in this country since the 19th century. The populist health movement in the 19th century, which was led by women, just saying. And Barbara Ehrenreich, check her out, she writes lots of great stuff on that. And of course, we all hopefully remember that Hillary Clinton at one point was an advocate for single payer health care. So the idea that this is something entirely new isn't true. But I do think that it's unfortunately a sad reality of our current situation with the government that it's a decent argument to say that the Affordable Care Act was the best piece of legislation passed in the last 10 years. And that's just how low the expectations have been set in terms of what gets passed at the federal level. And the low level of satisfaction with it, I think, really shows that people are looking for something so much more. And so, I think there's almost an inspiration of, you're really going to rest your laurels on the Affordable Care Act? That's not what we want. That's not why we're sending you to DC to represent us. And that's why we have to, get out there, not just convince people, but we also need to seize power. And that's why we need to support people like Julia, get new electeds into office who are going to pass the legislation that we need, like single parent.
I want to piggyback off something Emma said. In the 70s, the welfare movement was largely led by women, most women of color. A cool example of really kind of the entire welfare fight, which was led by a lot of domestic workers, for example, is a thing called Operation Life, which sounds scary now, but it was the 70s, had a different connotation. It was a movement of women of color who were domestic workers who took over a casino in Vegas and basically held it hostage until a lawsuit permitting the expansion of Medicaid and Medicare in Nevada was heard and passed. And within 2 weeks it worked. It's really fucking cool. That's some militant feminism, and it really, really rules. My answer about the ACA is that the ACA really did one thing well, which is the expansion of Medicaid. I think something like 70 or 75% of people who got insurance under the ACA who didn't have before were covered with Medicaid expansion, right? Medicaid drives a 6.1%. People that now have Medicaid, we see a 6.1% reduction in mortality rate, 11.1% among communities of color. And we understand why. These are folks that have been systematically and violently denied access to care in the first place. So even the relatively meager expansion of Medicaid does a hell of a lot to help folks get essential care when they need it. But the other folks who are on the ACA plans, well, here's the shakes. Like, average median cost of a silver plan, median deductible of a silver plan right now is $13,250. 40% of Americans have less than 10K in the bank. So people are getting plans with the ACA, but absent robust cost sharing, which is a thing Trump's doing a good job of done, they can't even afford to have them, right? Like underinsurance, undercoverage really is a massive problem because there's no cost controls with it. And I found that people necessarily don't care a whole lot about, no one's like cheering for Blue Cross Blue Shield. No one's like putting the patch in the jean jacket for people care about the material goods that are afforded to them and the freedom from, the relief from their bodies, right? So I think an example of how we can acknowledge that the ACA did a lot of good for a lot of people, among them the corporations that receive billions of dollars a year in free subsidy from the ACA. But most of the people that are on Medicaid, people that are finally being given a chance to get insurance, and in states that have subsidy programs that are robust, not go broke getting it. I think we look to an example of Medicaid. We look to the song of Graham Cassidy, right? The reason Medicaid still exists in its current form is because people with disabilities fought to keep it that way. You look at the ADAPT protesters. You look at the Capitol, you see, yeah, hell yeah, man, they're the heroes. They're the reason we have these things. You look at people in the Capitol who went and got their wheelchairs broken, their trach tubes ripped out, thrown into a bus, driven to jail, and came back the next day. You look at that dude, I think Adi Sarkian, who's dying and spent his literal final days flying to the Capitol to protest. But people like this all across the U.S. They're fighting for the understanding that we are all but temporarily able-bodied, and so they are fighting for the thing that maybe one day we ourselves will have to fight for, a broader version of solidarity. When you give somebody something, they fight like hell to keep it. People hate losing material comforts. And so I think you can kind of tap into the parts of the ACA where folks benefit and say we are fighting not to roll these back, but to expand them to all people. You look at how welfare was fought against in the 80s, and it was the fear that somebody else is getting ahead, somebody's getting welfare that you are losing because you are suffering in understated inflation in the Rust Belt, and these folks are getting away with murder, they're getting free stuff. You're being made to suffer. Aren't you mad? And the answer was yes, but we aren't afforded that. We aren't bound by that. We are organizing under the fact that we are fighting for a thing that helps all people at the same time. And if you give somebody a small thing, if you give people in New York the New York Health Act, if you give people in Idaho and Utah right now Medicaid expansion in Maine, they will fight like hell to keep it, and more importantly, they will fight to win the next thing, right? You build solidarity is cool, but you build solidarity so that you can win power. and a movement which provides material relief to somebody now, whether it's small or big. DSA Cincinnati won a needle exchange for the first time, which is fucking incredible. Most folks will come out and fight for the next big things. All these things kind of pile together, and you can kind of build the matryoshka that helps people understand they benefited from the ACA, but demand the next bigger and just thing.
Absolutely.
So just one quick thing on Medicaid expansion. So there was a Supreme Court case, a sort of referendum on the Affordable Care Act called Sebelius. And in the headlines you probably saw like, shocking, Chief Justice Roberts rules to uphold the Affordable Care Act. And for the most part that was true, but Justice Roberts is perhaps the smartest, I think so, my areas, but people argue that he's the smartest person who's ever been on the Supreme Court, and he is incredibly intelligent. And what he did with that case was he upheld the individual mandate, and what got struck down in that case was mandating the Medicaid expansion. And the far right understands how dangerous moving from a position of universal coverage to universal provision is, how dangerous it is for their entire ideology of neoconservatism and neoliberalism. So I think that in itself is very telling as to exactly all the points that Tim was making.
Absolutely, yeah. That was really significant, and yeah, he's a very effective devil. We have time for one fast little go around, and then we're going to take questions from you. I will say that in the United Arab Emirates, if you're a citizen, if you're an Emirati citizen, they will pay for you to get healthcare coverage anywhere in the world, and it's amazing. Oh, okay, we literally have 1 minute, but I do want to touch on this. We've been talking about the specifics of the fight and what we have to deal with. But strategically, and in our sort of long-term vision of decommodifying society and how this fits into a bigger project of, the same dynamics could be applied to housing, it could be applied to, obviously, education. I mean, any area, the same sort of logic of why we would fight for single payer applies to so many other things. So how does this fit into a broader sort of strategic struggle, basically, in terms of our broader goals and what we're doing? And I'll start with you.
Yeah, hell yeah. I try to outline that a little bit in my speech, right? It's population health, it's health justice, it's socialism, all these things kind of intersect in a little funny Venn diagram. Right now, nobody is held accountable. There's no accountability. Nobody gives a fuck if your pipes burst and you get bookworm. Nobody gives a fuck if your neighborhood has been polluted and robbed from and punished. You send the cops in to punish people for being poor. Nobody fucking suffers. A single payer is a pretty benign transformation, right? You're shifting over a column in Excel for who's footing the bill at the end of the day. But that transformation creates an accountable party. Suddenly, the state is on the hook for all the ills we inflict upon people, the ills of insufficient housing, the ills of unsafe food, the ills of letting cities have all their resources extracted, nothing returned, and letting people suffer, the ills of letting people go hungry, the ills of letting people get shot by the police, the ills of letting people live in unsafe structures. Finally, somebody is held accountable for it. It's the single payer. So finally, we have a tool we can use to push the resource allocation, to push the money into the things that prevent these problems in the first place. The simple economic argument isn't really good enough for me. This is not like a simple libertarian proposition. What it is an opportunity to build a thing that, one, benefits people now, and two, can and must be harnessed to realize a broader vision of a better world.
Yeah, I definitely, the broader vision of a better world, that really resonates. As socialists, what our ultimate goal is to construct a more caring society in which everyone has what they need to thrive. And I think that that fighting for single payer is definitely at the heart of that, and can be the source of a larger conversation about all of the other issues that intersect with this. I personally, I think that it can produce more of a conversation about labor, about the workers and the jobs that are going to be demanded by a single payer system, and how we are not only thinking about making sure that everyone has access as patients to medical care, but additionally that all of the people who are taking care of us and of our elders and of sick people are being treated with dignity, and that those are quality jobs.
It was Karl Marx's 200th birthday recently. One of my favorite things that Karl Marx pointed out, it's actually a fairly straightforward thing, which is just that the behavior of consumption in a society is directly the consequence of the means of production in that society. And so for me, I believe that our economy should be democratic. It shouldn't be controlled by a small 1% of the population. And I think politically, the way we get to a place where we have a society where we're producing things because they're good rather than because they're profitable, the way we get to that is by starting at the most fundamental level. And that's why I was so excited that DSA was really jumping into single payer. That's why I'm really excited that Julia is running, and many other candidates across the country, mostly women. It's a really exciting time despite all the terrible things that are going on. I really think that we are seeing a fundamental shift, not just in terms of healthcare, but in the way people look at the economy as a whole.
Just 30 more seconds. I just want to say, yeah, I think it's exactly right. And I think of single payer, for me, I think it's like the tip of the spear. I think it's like the type of fight that, because of where it's centered in our economy and because of the basic ethics and necessity of it, and the shift from private to public concern, that it's a one area, like that win, and for labor, more room to organize. If that's not something that is terrorized over you and lorded over you by bosses, it has such a broad ancillary effect. But Tim wanted to add one more thing, and then we'll get to you guys.
Cool. One thing right off of what Julia said. There's an interesting question in healthcare. What drives better outcomes? What drives population health? Take, for example, someone who has a heart attack and goes to the hospital, gets a pacemaker. What keeps that person from readmitting to the hospital within 6 weeks or more, right? You've got a couple options, right? Is it the surgeon? Is it the pacemaker itself? Is it the cardiologist? No. Those are the people that get to charge the most. The people who make an actual difference are the social worker, the nurse, the nutritionist, the patient advocate. All these jobs of compassionate labor, what would still be a favorite to call it feminized labor, but jobs that comfort and persuade and nurture and nourish and soothe are the only things that actually drive better health outcomes. I visited a hospital in Little Rock that invested in those folks, right? Hired a couple social workers, a couple nutritionists, had people go into 3 times a week Medicare sponsored nutrition classes, cooking classes, exercise classes, and saw their readmission rates fall from 26% to 4%. We understand who it is that does all the work that makes people healthier. It's people that do compassionate labor, but right now we refuse to value them, right? We refuse to pay them fairly. A single payer is forced to consider this workforce. It is forced to give the labor the money it deserves for the essential work that it does.
It's the tip of the spear. Okay, we're going to take questions. Jamie? Sorry, like how many minutes? About 5. All right. So your questions need to be super efficient. I'm just kidding. Is there a mic out there or no?
No, I can pass it to.
Or start with you. I see your hand back there. Can you project?
Yeah, I'm young and fairly new to this. What are some top 2 talking points for running a single payer? I feel like I have enough to go on, but I want to that's clarified.
Top 2 talking points. I like that question. And I'm going to pass it on.
So first off, I would say if you really want to hone the way to talk to people about this, you should come out canvassing with the New York City Socialist-Feminist or the DSA. In fact, I believe today they were canvassing at Elmhurst Hospital in Queens.
And there's a South Brooklyn campus on May 26th.
Thanks, Jen. So yeah, May 26th, come out to that. The two things that I most often talk to people about, people will often respond by saying, oh, I already have insurance. And I point out the fact that, that statistic, that the majority of problems in our healthcare system actually come from not having enough insurance, and that just because you have insurance now doesn't mean you're not going to have problems going down the line. So we need complete coverage. The second thing I hear most often is the problem of cost. And in terms of this sort of bullet point, I think the best sort of thing to point out is that the Republicans just blew a what was it, like 1.4 trillion, I believe, hole in the budget through tax cuts. And the question is why do we always find the money for war and for the rich, and we don't find money for healthcare?
Yeah, and I would just add, I don't know if these are great they're decent talking points, but I just said, full coverage, no bullshit, and you want to not have to be on the phone with your insurance provider ever again. And if people actually buy that, then you're good. Do either of you guys have anything else on the top two talking points to add? Or?
That's helpful.
Awesome. Next question. Everybody's just ready to go. They're like, all right, let's go get it at now. Yeah.
So, you kind of mentioned some of the models in other countries. Have we learned that much in terms of which systems work the best? You mentioned Canada, you mentioned United Arab Emirates. Sweden, I think, has a system.
Cool. So the question was about what can we learn from other countries. Do the fun part first. We've learned what certainly doesn't work. Right? We've seen it. There was the OECD, which is a big European group that puts together comparative papers of healthcare and other shit in much of the countries. Recently put out a paper about healthcare finance in South Africa. South Africa tried to do something that we hold pretty dearly in the U.S., where they made room for the private market. So they have a universal insurance provider that you can opt into. But if you have money, you can pay money and go to the private insurance market. So your premiums are taken out of the pool and put in the rich one. And so here's what happens 15 years later. The private insurer spends 46% of all healthcare money spent in South Africa and covers 13% of the people. The OECD, not me, the OECD says they are literally reenacting apartheid through healthcare finance. All the rich white folks get nice fucking lavish hospitals, everybody else gets shit. They die sooner, outcomes are worse. That's what happens. In Australia, they introduced the idea of private finance for things like orthopedic surgery, hip replacements, knee replacements. What happens there? Anytime a private investor or a private payer invests in knee surgery, it costs 4 times as much, takes about as long, and only goes for rich folks that want fancy hospital beds. The fundamental lesson that you learn from any kind of model in other countries is that when you create a bifurcated pool, when you let rich people opt out, they're always going to get better care that comes literally at the expense of the rest of us, right? Now, some people might say, what about Scandinavia or Germany? Which, of course, ignores the massive differences in the way corporations are regulated in Scandinavia and Germany. But even in Scandinavia, which was the kind of model for the ACA, 21% of Scandinavian people, the Dutch, I guess they're called, lack access to healthcare because of costs. In Germany, you still have a federal insurer that insures all people, even if they don't have ESI. And also, there's a long history of regulation that doesn't exist in the U.S. So the thing that we've learned is anytime you let somebody not pay their fair share, anytime you let the rich folks have the world fucking oasis, that comes at the expense of other people, people suffer.
Absolutely. And the World Bank dimension of that South Africa policy is really interesting to look at. We have time for one final question. Or not. What do we do?
What do you think strategy-wise about including more coverage for mental health issues?
Absolutely essential. I guess I'm jumping on this. I want to pass Julie in a second, but at least for me, when I talk about healthcare coverage, I'm talking about every single thing that could possibly be conceived of inside, mental, dental, everything.
Yeah, I mean, talk about like a public health issue, right? Is the lack of access to mental health services that we see in New York and all over the U.S. That's got to be a key demand. And part of the New York Health Act is expanding access to mental health services. We've seen the results of people not, en masse not having access to psychiatric care, and the result is that most often people with psychiatric disabilities end up incarcerated, end up like institutionalized, and it's preventable, right? Our society doesn't have to be this way, so we have to expand access to mental health services.
I guess the only thing I would add to that is I think some people have very correctly identified gun violence as a public health crisis in this country, and it's worth noting that actually the majority of gun violence in this country is suicides. We have a mental health crisis in this country. We've been having it for several years. It's long past time that we started addressing it with actual care, that our government actually does something about it rather than just continuing to talk about it, or even worse, blaming and incarcerating people with mental health issues.
Absolutely. All right. I want to thank everybody. I want to thank DSA, New York, DSA, Jamie, thanks for putting this together. Thanks to everybody who put this together. Thanks to all of you. All right, let's go get to it.
I just want to thank you guys again. Thank you, Tim. Thank you, Michael. Thank you, Julia. Thank you, Emma. That was an incredible panel. Thank you. I also just wanted to give a quick shout out to all of the volunteers that helped put this event together and helped put it on today, because you guys did such a great job. I want to thank everyone that spoke today. I want to thank After Hours Project. If you still wanted to get a Narcan kit, they're over there at the table. I want to thank the Socialist-Feminist Working Group, DSA Medics, and Salazar who did the yoga training, and Emma who did the consent-based sex ed. You all did a wonderful job. Thank you so much. We have a donation bucket over at the front and a bunch of DSA merch and some more information as well. So thank you, everybody. And we will have healthcare for all soon enough. All right, thank you.